Good morning, everybody.
Swim through the moat now.
Did you all enjoy yesterday? Good. It was a long day, right? I know, but I think people are still waking up this morning. So I want to welcome you to the workshop this morning, Your Skin and Chronic GVHD. My name is Karen DeMiro, and I am the Director of Patient Access for Leukemia and Lymphoma Society. So I oversee the patient programs in a number of the chapters in the Northeast region. So I'm going to be moderating for this morning, and it is my pleasure to introduce you to Dr. Sebastian Mayer. Dr. Mayer is an assistant professor of medicine at New York Presbyterian Weill Cornell Medical Center and an attending physician on the stem cell transplantation service. His research focus includes the management and diagnosis of chronic graft-versus-host disease and the prevention and management of graft rejection and transplant failure. Please join me in welcoming Dr. Mayer.
Thank you very much for that kind introduction. Thank you, everybody, for coming here at this early hour. I know it is an effort. And a friend of mine, Amir Steinberg, is giving a talk across the hall on the topic of fatigue, which is probably the much more appropriate topic at this time of the day. But we'll manage to get through it. So thank you again for being here, and I'm thrilled to talk to you about GVH, even though we're more thrilled if it didn't exist. So let's try to make this a fairly quick talk so there's more time for questions. What is graft-versus-host disease? You probably all know. I will just quickly give an overview. It is basically the reaction of a burgeoning immune system that is in the wrong place. It is transplanted into a new body, and at times it can sense that the tissue and its own are not compatible, and it mounts an attack. This can be in the acute setting in the first couple months after the transplant, or what we will be talking about in the chronic setting, a couple months until many years after the transplant. And the term chronic already implies that it is a condition that you will be dealing with for quite some time. How common does it occur? You see on the slide, skin graft-versus-host disease is the most frequent post-transplant complication in 40 to 80% of patients with chronic graft-versus-host disease. Now, this is quite a spread. I could also just say 50%, but it depends on which type of disease, which type of conditioning, which type of graft-versus-host prophylaxis. So in every statistic that we cite, there will be a wide range of numbers, but the take-home message is that it's common. It is mostly the earliest sign of any kind of graft-versus-host disease, and obviously it's not so hard to detect. It is on the surface of your body. Some patients develop deep scarring up front. That's not so straightforward, and we'll show a picture so you get an idea what it looks like. So what does it look like? How does it manifest initially? Well, there can be rashes, color changes. You can have hyper or hypopigmentation, meaning too light or too dark. In a light-skinned person, hypopigmentation may not be so manifest. When you develop dark blotches all over your body, you'll notice. And then in the further course of the disease, if not treated, or sometimes despite the treatment, you can develop scarring. And there are various types. For instance, they're all listed here. The superficial type, which is like a burn scar, if you will. It leads to tightening of the skin, to thickening, to decrease in elasticity. It can be so severe that it leads to what we call hide-bound skin, when the skin is attached to the subjacent tissues, such as the fascia and the bones. It feels like wood, if you will. It can be manifest as fasciitis, means only affecting the tissues below the skin. The skin will look normal, but it's still tight. And it's very slow to develop, but like everything that develops slowly, it goes away slowly or doesn't go away at all. It can also affect the appendages of the skin, that means the fingernails and the hair. You can get ridging, chipping of the fingernails, similar like somebody who you think has a vitamin deficiency. And it can lead to hair thinning and hair loss. Now, you already lost your hair from the chemotherapy, it comes back, and then you get GVH and lose it again. That is sometimes the cruel irony of what happens to transplant patients. What are the symptoms? Well, it's pretty straightforward. You don't need to be a rocket scientist to guess what the symptoms are if your skin is affected. Well, you'll be itching, you'll have some tightness if it's scarring, you can have restricted range of motion, which is not from arthritis, but what I call arthritis from the outside. If the skin, for instance, over your elbow starts to become thicker and tight, then you just can't bend your elbow that much. Normally it's not painful, but some people feel a burning or weird tingling sensation, which can often be also medication side effect to the nerves. It's often not so straightforward where the symptoms come from. Now, a picture says more than 1,000 words, as they always say. This is early graft-versus-host disease. I wrote it can begin subtly. This is people that come into clinic, they have some red areas. Sometimes if they're someone with hypertension and they already have a red head, you may not even notice, or it's under the hair. It doesn't really itch much. And in such a case, you watch and wait until it really becomes something you should treat. This is more widespread, and I will not torture you with much technical terminology, but there are few skin manifestations that are very typical of chronic GVH. And one is called lichen planus ligations. These are just areas of skin that are red, they're somewhat elevated, they're map-like, they can have all kinds of shapes, they can be confluent and demarcated, and they have some scaling, dandruff-like structures, and it is quite itchy. And when you see this, and this is pretty widespread, well, this is an indication that we need to treat this patient. The last technical term that we'll go over is Poikiloderma, because this is what we call pathognomonic of chronic GVH. You have it only in chronic GVH and in nothing else. Poikilos in Greek means many different shapes. So this is a change of the skin where you see in a small area there are many different colors. You can have dark, brown, white, dip, loss of pigment, addition of pigment, loss of hair, and on magnification it may look like a leopard fur, all these different colors. This, if in a small area and not necessarily symptomatic, is something you can watch and wait. And these, what we call focal sclerosis or focal scarring, is thickening of the skin in a small area. For instance, on the neck of this patient, it starts to look a little bit waxy, shiny, and there's loss of hair, and over time it becomes hard and immobilizes the tissues below. Now, if it's a small area like this, it's not that big a deal. But mostly it doesn't stay that well, and it can extend to areas that are more sensitive to this because they're areas of movement. For instance, joints, wrists, ankles, knees, and then it becomes critical because you can't really move. Or around the chest, and chest expansion is necessary for breathing. So these are more severe cases and of sclerosis or scarring On the upper left, you see a leg with an area that's darkened. And of course, this is not 3D. You don't see the thickness of the skin, but this is an area of scar where the skin is thickened. And scars lead to traction. That's the way a scar heals tissue and makes it more stable. It thickens, and the fibers, the protein fibers, they slide into each other and shorten the tissue, reducing the range of movement. So this person may not be able to fully extend their knee. The same here on the forearms of this patient on the upper middle picture. You see this shiny aspect of the skin, and it's thickened and really leads to decreased range of movement. The same on the belly, or here on the lower left side. This is what we call deep sclerosis. You don't see any skin rashes or discoloration, but this patient has scarring of the tissues below the skin, of the fat tissue, and that leads to small fiber strands under the skin that retract the skin. It gets this dimpled aspect, like what we call cellulite. And then in the middle here, this is what we call sclerosis of the tendons, shortening of the tendons in the hand. And these patients cannot fully extend their fingers, especially if they assume a Buddha position. It will be like this, because the tendons are so short, we can't extend the fingers. And this can lead to significant disability. You certainly can't play the piano with these hands, or even hold a pen. And F, this would be the more advanced and painful type of graft-versus-host, but we certainly don't like to see. This is extensive scarring and sclerosis of the legs with development of ulcers and leakage of fluid and bleeding. This can be very painful, and this opens ports for infections, further complicating the course of the disease and the treatment. This is a typical fingernail. I thought one nail should be enough. I didn't want to show a full hand, but believe me, they all look bad. And this doesn't kill the patient, but it's a nuisance. People still want to look good, even after transplant, and it can be painful when the nails break. And sometimes just some vitamin supplements can help with this. Now, what are the treatment principles? I'm not going to bore you with 1,000 different drugs, but it's important to understand how we treat this disease. The first step is you got to control the symptoms. You got to make the rash go away and the itch. With every treatment, there is collateral damage. Nobody knows that better than the patients who went through a transplant. So you want to prevent further organ damage, both due to progressive graft-versus-host in invisible areas, such as the GI tract, the lungs. You want to minimize toxicity. You want to minimize the damage perpetrated by the physician. You want to avoid late damage, cumulative toxicity from drugs. And you want to maintain what we call the anti-leukemia effect or anti-myeloma or lymphoma effect of the new immune system. And that, of course, is a difficult task because that is something that happens on an invisible scale. And we can only surmise that further immunosuppression will dilute the graft versus leukemia effect. So, taking into account these principles, how will we treat? Well, in medicine, there's always two basic treatment approaches. Systemic, treating the whole body, or local, or topical treatment, which the skin certainly lends itself to because you see where the disease is. Now, if it's an isolated area, you will treat with a cream or an ointment. If you have a rash from head to toe, you can't immerse yourself in steroid cream. So that'll be a case for more systemic treatment. Rashes as you see here, are mostly easy to treat because rashes are a sign of active inflammation. And active inflammation mostly responds to anti-inflammatory treatment. Scars and color changes are not so responsive. And I had an old professor of dermatology when I was a student, and he said, in life there are only two things that never go away. Two things you have to recognize. One is the fact that we die, and the other one is the persistence of a scar. Hopefully, part two of his statement will eventually be refuted, but it still holds true to some degree. I can't really offer any consolation on the first part of his statement. So the first medication, first rule of thumb is that we treat with steroids, prednisone or cortisone, hydrocortisone. There's many different types, and they're given intravenously or by mouth. Obviously, mostly by mouth if the patient has no issues with drug absorption, because all of these things should be treated on an outpatient basis. Only in the worst and most severe cases would we have to admit a patient for intravenous treatment. And then there's many treatments on the side track that we can provide to alleviate the symptom burden, like a regular Benadryl to relieve itching, or hydroxyzine. All these are antihistamines, or ancillary supportive topical treatments like skin moisturizers, creams. There's a whole world of supportive treatment out there. Now, some words on topical treatments, which is probably more interesting because the patient applies it himself. So the first line is always steroids. All of you have heard of steroids. It's not the steroids that the baseball players take. In fact, the side effect profile is quite the opposite. It leads to muscle loss. But what we do, you put a steroid cream on the affected area, and eventually, over a very long time, in scarring, the lesions can get softer. Rashes respond quicker, as we said, but steroids have their side effects. And the most visible of them is skin thinning by metabolic degradation of the proteins that keep the skin tight and elastic. So people get bruises just as if they have no platelets. They get skin tears, and they got to be very careful. There are topical immunosuppressants. Everybody knows tacrolimus because that was part of your initial immunosuppression. That can be given as a cream, and it can be a helpful adjunct to the steroids. You can use moisturizers because often people get dry and flaky skin. They don't have activity against GVH, but they can largely help with the symptoms. The usual anti-itch lotions or creams that are used over the counter, like camphor, that provides a sense of cooling, or the antihistamines that really take away the sensation of itching. Now, in the worst case, if you have ulcers, they need to be protected. So, because they can be infected. And yet you still treat them with steroids, often under an occlusive dressing, and over time they shrink. But it's a real test of patience. It can take months and months and months. And in that time, mostly you will also need some antibiotic cream, a protective film, and specialized wound care. So wound care nurses are an invaluable part of the treatment because they know the patient's skin mostly better than the physician. There is this mention of hyperbaric oxygen. That is a treatment originally devised, well, for diverse sickness, but it's used mostly for burns, and it really helps with burn scars. given that the burn doctors have ownership over this, good luck to the transplant physician who tries to get his patient into the hyperbaric chamber. It's almost impossible. So I just mentioned this for completeness sake. But now there's some more esoteric treatments that are gaining widespread use. One is what we call Poobah. P stands for psoralen, and UVA is ultraviolet A. Psoralens are substances that sensitize tissues to UV light. And you can take a psoralen and then radiate the affected area with UV light, and there can be a response. Now, this obviously only works for areas that are limited. You can't photosensitize the entire patient and then put them in the sun because they'll look pretty red. So this is for limited areas of the disease. You can also use UVB light. That's like going to the sun studio, the tanning salon. Responses are mixed. Some people respond, some don't really. But the probably most exciting area is what we call extracorporeal photophoresis, or just photophoresis. It's exciting because it works in some patients in whom nothing else works. It's also exciting because we don't understand how it works. So there's, in a way, it's the closest we get to voodoo when we treat our patients. It requires a machine. The outward principle is easy. You get hooked up to a machine with an IV here and one here. The blood goes out. Your white cells are separated and go through the machine through a bath of psoralen again. The UV light radiates them, and then everything goes back to your body. So what the UV light does to the sensitized lymphocytes and other co-perpetrators in the activity of your graft-versus-host disease is it seems to sensitize them or kill them, but sensitize them to your own tissue. And this treatment is not as immunosuppressive as steroids, for instance, or tacrolimus. So people may not get that many infections, but it's cumbersome. You have to come to the clinic. You have to be there 2 days. You get hooked up to the machine. You need to protect yourself from light for the first 2 days after it, because some of the psoralen is still absorbed into your body, and we provide you with a very elegant sunglass model from the 1950s, and big hat. And this works quite well for patients who have resistant skin graft-versus-host disease, but also for graft-versus-host disease that's in other parts of the body, which is kind of counterintuitive for a light therapy. But remember, the light is directed on the immune cells that mediate the graft-versus-host disease, and then they go to wherever the damage is done. So much for photophoresis. Very expensive treatment. The insurance companies do not like it. Then there's the whole world of ancillary and supportive care. This is a slide that I plagiarized from Dr. Lee. You can do massage, as you see here, stretching, physical therapy. All these things can help. And I would actively endorse any kind of physical therapy, massage, especially for patients with stiffened skin, because the medical treatment alone will not result in the optimal outcome. Now, I think what's important for patients is not only how we treat graft-versus-host disease, but what precautions are needed, because what are the other problems that can arise in your skin. So obviously, know your skin, protect yourself from sun. That's what they preach on TV and the newspaper, everywhere. Everybody knows that. What is maybe not so well known is that graft-versus-host disease and simply being immunosuppressed and having had a transplant significantly increases your risk of skin cancer. And that is something every post-transplant patient must be under strict surveillance for, because nobody should die from skin cancer and nobody should be disfigured from skin cancer, because it is something that can be detected early. Skin cancer is still the most common cancer in the United States. These are statistics that's probably not so interesting, but 1 million of people are diagnosed every year. That's like 1/3% of the entire population. This doesn't get the big press because it's not the cancer people die of, but it's still a big burden on the patient. And it is increased in immunosuppressed patients. And it can mostly be treated with minor surgery or more extensive. Most surgery depends on the type. It can also be treated with some topical chemotherapy or burning it out. But after 20 years in a transplant, you may have a 7% risk in basal cell cancer. And that is 1 in 15 patients. And it may be even higher. There's a 3% risk of the more malignant squamous cell cancer, which is a cancer that, opposed to the basal cell, can metastasize and it can kill you. And not only having a transplant, but as I said, also a history of graft-versus-host disease significantly increases this risk. Now, you should know what a skin cancer looks like. Ultimately, I would leave the diagnosis to a dermatologist. We start with the most benign, in quotes. This is the basal cell carcinoma, called because it arises from the basal cells in the skin, the lowest cells. And it starts out like a roundish, half-dome, pearly, waxy, shiny lesion. Can have raised edges. It often has some little blood vessels that are visible. They're called telangiectasias. Or it's just a sore that doesn't heal. Anyhow, you see this nose, and there's a small lesion that somebody who's not that concerned with their exterior, a population that is shrinking in the day and age of People magazine and TV, may not notice until it's really bad. And if you look at the lower picture, this is how bad it can get. It can be extremely disfiguring, from a small wart on your nose to a huge crater in your face. And this is then really hard to treat. People often get what we call facial prosthesis, because you just have to excavate the whole lesion. And this is certainly what we should never see. That's why, depending on the patient, everyone should have dermatologic surveillance, and I said between once a year or even more frequent, depending on how bad the graft-versus-host disease is and whether you've already had a skin cancer. I have some patients I send to the dermatologist every month. And every month he finds something, which I would not find, because the dermatologist looks at skin for breakfast, lunch, and dinner, and they are obviously much better at diagnosing this than an oncologist. The second type of cancer that you can get is squamous cell carcinoma, and if you look at it, for us, it looks the same as the one before. But it's more malignant. And again, it's just a scaly, crusty bump, not as shiny as the one before, but who would really know the difference? It's as the basal cell, also mostly in sun-exposed areas. Very typical is the lower lip. If a transplant patient gets a lower lip lesion that doesn't heal, the first guess should be skin cancer and not herpes simplex, because herpes simplex we can treat, it goes away. But this has to be dealt with in a more radical fashion. And it can spread. So a cancer that metastasizes can kill you. And the worst, thankfully the least common, is melanoma. Melanoma is the cancer of the skin that gets the biggest press because it is malignant, and you can have a small spot on your skin, and it can already be everywhere in your body. So this is something that needs active surveillance, and it has, conveniently, you can characterize it by A, B, C, D, E. First of all, it doesn't look like a simple mole. It always has some weird shaggy borders. It's asymmetric. It has various shades of color. It's mostly not that small, and it grows quite rapidly, and it changes. And this needs to be surgically removed because there is to date no other treatment. So much for all the horrors and complications of graft-versus-host. Just as a small practical guide, what should we not do? It's always easier to tell the patient what not to do than what to do. Do avoid cosmetic surgery. You'll end up looking worse than before, sometimes even in a healthy patient, because scarring can be extensive and certainly not in graft-versus-host disease areas. The outcomes are very bad. Avoid the sun for reasons that we mentioned before. Also, lightening products, they can just worsen the skin GVH. And if you have skin thickening, that leads to chafing of between folds. Well, don't run a marathon because it'll just get worse. But I do endorse exercise. But if you're sweating profusely and you have these skin lesions, they can get nastily inflamed and infected. So these are the few things that one should avoid. I think we are slowly coming to an end. This is probably an important question. Does it go away? I will tell you, even if a patient may be hounded by it for months and years, it can go away. Even some element of scarring can eventually resolve, but it takes 2 to 2.5 years of committed treatment, and many lesions do not resolve. So the worse it is, the less likely it is to resolve, unfortunately. Some joint stiffness may remain, but that is where physical therapy and the adjunct treatments may be very helpful if the pure immunosuppression that we provide is not of benefit. You can largely benefit from the side avenue of adjunct treatments. And it takes years to resolve. So the average treatment duration for any type of chronic graft-versus-host disease is 2.5 years. There are some new treatments under investigation for what we call steroid refractory or resistant graft-versus-host disease. And unfortunately, in chronic skin GVH, more than half of the patients will have to embark on a secondary treatment. They're what we call antifibrotic, anti-scar treatments, Imatinib and Melanoma. These are drugs developed against chronic myelogenous leukemia, but the receptor, the cell surface protein that it attacks, is also one that promotes scar tissue. And then there's a new immune modulatory agents, interleukin-2, tocilizumab. There's something called Jakafi that's used for myeloproliferative diseases, and it was just studied in 6 patients, but they had an astounding response. So there are new things on the horizon. And we have a chronic GVH consortium that many of the hospitals, even locally, are part of, and they have all these trials that are here listed. Unfortunately, the first trial, Rituximab versus Imatinib, is already closed. We have another trial for Melanoma, and many drugs that are actually used for different diseases, but they have immunomodulatory properties than are tried by default in chronic GVH, because if you have nothing else, you try something that was tried somewhere else. Carfilzomib is a drug for multiple myeloma. That's under investigation. Tocilizumab is something that's used for inflammatory bowel disease. Interleukin-2 is used for renal cell cancer. And all these treatments can have some response in resistant graft-versus-host disease. But again, there's nothing of which I can say, oh, 90% will respond. It's more like 20%. And that's why many patients go through the ladder of one treatment leading to the other until something works. There's no way of knowing what works best. So in summary, it's common. We treat according to its severity. We would rather treat with less immunosuppression, but sometimes if you have disease all over your body, we need to be more aggressive. And some changes may be permanent. Some changes will be permanent. And with that, I want to give special credit to Dr. Lee from the Hutch in Seattle, as I modeled my entire presentation after the same one that she gave last year. And honor is due to whom it's due to. This is where we work, and thank you very much for patiently listening, and we can open the floor to questions. Yes.
Just use the microphone when you ask the question, because we are recording. And we're also joined by Phyllis McKiernan, who is a nurse practitioner, so your questions can go to either one.
Thank you. On your slide for procedures to avoid, you have, for lightening, you have 2 chemicals mentioned, which I can't say. My question is, what about a retinol-based cream for, I guess, smoothing and bleaching versus what you say not to use? And if there is if one is okay and one isn't, could you kind of explain the mechanism so that we can figure out if this dermatologist has us run on the right track?
Yeah. So, and maybe you can chime in then too. There are many different retinoids. These are actually drugs that work on gene expression, and it's not so clear what to use and what not. If the dermatologist recommended something, I think it's okay. There are some retinoids that can dry the skin. Those are mostly the cheaper ones, but and that's one of the concerns. It's not so much of worsening the graft-versus-host disease, because in our patients who have recurring skin cancers, I actually give systemic isotretinoin, and it really has shown to decrease the rate in which skin cancers pop up. So if it doesn't dry the skin, you can go ahead.
So for drying the skin, you're concerned about having open lesions and then concerned about infection. Is that kind of how that goes? Or does dry skin have a concern other than lesions leading to infection?
No, dry skin doesn't per se lead to infections, but it just leads to scratching, and it can lead to that on a roundabout way.
Okay.
Hi, I'm over here.
Hi.
I have a lot of skin thickening and reduced range of motion and other things, but I've just started a regimen of Gleevec, and I was wondering if you could comment on the efficacy of Gleevec.
Yes, so that's a good question. They're all good, by the way. We are in the process of closing a trial where we randomized patients to either Gleevec or a drug called Rituximab. And the Rituximab arm was quite disappointing, while the only real responses that we saw were in the Gleevec arm. But it takes several months to really work. But I think if you're getting Gleevec, that's a very good opportunity for you.
So what is the therapeutic level of Gleevec, in your opinion? The way we're working it is we're ramping it up slowly because of the potential side effects, I guess. At what point does it start working, or do you have any data on that?
That we don't really know yet. Sometimes we start at 100 milligrams and then go up to 400, which is the usual dose for CML. The major side effects are that it can drop your blood counts, or you can get some swelling. But that drop in blood counts is mostly not that severe, but we certainly would not endorse a higher dose than 400 milligrams. So that should fully suffice. It may even work at lesser doses. How much are you taking now?
I'm up to 300.
Okay,
So-
you're almost there.
Thank you.
Yeah, in our experience as well, we've had patients on Imatinib, and we basically will probably start at 100 milligrams, and we go as far as the patient can tolerate it. So once the patient starts to have side effects that they can't tolerate, then we would either drop it down or stop at that dose. And we have seen some responses as well.
Question?
Well, a comment really. You had mentioned about the hyperbaric oxygen, and it sounded like you were saying most insurances won't cover that, but I just wanted to comment. I don't know if you'd say lucky enough to have my insurance cover that for me for an attempt at wound care for the skin GVH that I have. It's on my lower left leg. It didn't really help very much, so if there's anybody out there I know everybody's different, but if there's anybody that's looking at it, you should just know it's a long commitment of time. It's 3 or 4 hours a day for like 6 to 8 weeks, and often there's a lot of driving involved as well. It didn't do very much. It did give me quite a good little energy boost. That was the only benefit I really got out of it.
Maybe we should prescribe it for that.
Yeah.
I will
I'm
tell
sure of that.
Amir Steinberg, who's giving the
Okay.
fatigue talk.
Great. And then my other comment was about the Gleevec. I have two physicians who were a little at odds about whether or not to try that, but my insurance wouldn't cover that anyway. So, which one doctor really was having trouble with understanding why they would pay, I don't know, probably $50,000 in charges for hyperbaric treatment, but they won't cover the Gleevec for me.
The ways of the insurance are mysterious. But I can understand that maybe some physicians were a little reluctant to start Gleevec because of its possible interference with wound healing.
Oh, is that right?
It's a theoretical risk, let's put it that way.
I had my transplant 5 years ago, and I've dealt with skin GVH, and I did the Rituxan, and that didn't work. And then we did steroids. These steroids are just awful. He put me up to 100 milligrams of prednisone, and since then, every time I get down to about 20 milligrams, it all comes back. So I have done photophoreses, and they told me that they didn't think that the photophoresis would take away, because I have the eye issues also, and all my mucous membranes. Which would that all be considered skin, or like my oncologist said, well, the eyes, is that, it's skin.
I wouldn't call the eye skin.
No.
That's why the ophthalmologist treats them, and not the skin doctor.
Yeah. But the steroid, like if you were to look at my skin, I would say it looks like what all those pictures look like. But my oncologist says, no, that's from the prednisone. You've been on the steroids so long, you have the thinning of the skin. I mean, if I just rub up against the sheets, it rips my skin.
That's the very bad side effect of the steroids, because they just degrade the proteins, especially if you are on long term.
So they said that the photophoresis, because the dermatologists are the ones that do the photophoresis, and they say that it could help me get off the steroids. They weren't convinced that it would get rid of my chronic GVH, but that it would help me get off the steroids, and then I wound up with a hospital-borne infection and back up on the steroids again.
That's kind of the chicken or the egg question. You can only get off the steroids if you get rid of the GVH, or if it calms down. So we call these interventions steroid-sparing interventions. We start something else in the hope that there is response enough that we can taper the steroids. Although some patients may never get off a certain basal dose. And that's, of course, tricky. Even if it's just 5 milligrams, it builds up.
Another question right here.
Leaving Poobah out of it, could you speak to UVA1 treatment versus UVA, standard UVA, and UVB? Different dermatologists have talked about different, depending upon what's available. But UVA1 was mentioned as specifically.
Yeah, well, UVA is mostly used for Poobah. Do I know whether there's a real big difference between UVA and UVB? In all honesty, no. Do you?
No.
These are treatments we actually don't prescribe that often.
No, we've never prescribed it.
We do more photophoresis or Poobah because it seems to be more effective for a localized area.
Mm-hmm.
So I'm sorry if I can't really sufficiently answer that.
Another question?
Hello.
Hi.
Rituxan actually worked for me. It gave me my skin color back to normal, but and it did help with my range of motion, but my nails are still brittle. Is there any supplements you could suggest to help with that, or treatments?
No, go ahead.
So I often prescribe silica-containing vitamin supplements. Silica is silicium. It's in the nail substance. It's what microchips are made of, and it can help. It doesn't necessarily reverse it. But recently, I had a patient. His nails they look like on the picture, and he took that for a couple of months, and it's getting better.
I've had issues with my skin that were affected, that were helped very much by Protopic, the tacrolimus. Getting back to the phone of insurance issues, they have denied it when my employer switched coverages, and it went through an appeals process. I didn't have the ointment for about 3 months. And once it finally did get approved, I was improving, and now it's going to be denied again. Are there keywords? Are there research that I can send to them that would make this process easier for the approval?
So the easiest way, you can just go to pubmed.org and type in topical tacrolimus and GVH, and there's not a big randomized study. Somebody gets nothing, the other gets tacrolimus, but they're case series. Fortunately, this is a rare disease. Unfortunately, for clinical trial design, it's hard to accrue patients. So you will find some small series that provide evidence that it can work, and sometimes that's okay for an insurance. We have successfully prescribed with insurance some more esoteric stuff, and they go with it if you just bug them enough.
The other thing that we would do, too, is provide evidence of trying something else that didn't work. So sometimes that can help as well. They want you to try their first line, whatever they want is in their formulary, and then once you provide evidence that doesn't work, then they could possibly approve the Protopic.
Hi, I'm a mom of a 10-year-old who is 8 years post bone marrow transplant.
Great.
Yes. He has several complications with skin and joint graft-versus-host disease. He's tried almost everything on this list, and right now we are down to the IL-2 therapy. We're doing low-dose daily shots of that, which seems to be helping in a small amount. My question is, have you seen a child with the joint and the skin issues go through puberty? And if so, what complications were made by, we're also doing growth hormone therapy. So we're forcing the muscles and tendons to grow or to be pushed to an extent. And my fear is that we're going to make him less functional by forcing it to go too fast. And if you've seen a child either with or without growth hormone go through that puberty process, and what complications, if there were any, were made from that growing on the tight skin.
So I don't treat children.
Okay.
So the answer is I did not see it, but I can see your concern. Now, growth hormone treatment is also used in some adults. It's also used in the sports world illicitly. I think this is not an expert opinion,
Right.
But I think it can be helpful in reducing the growth retardation brought on by the steroids, which your child, I'm sure, has been on to a great degree, because if you see a picture of a child who has had asthma all their life and a healthy one, the asthmatic will be much shorter because of the steroids. I don't think it's forcing the body to grow out of proportion, because everything should be underlying the growth signal. And with regards to the IL-2, it takes very long to work, but
Very long as in
Several-
years, or
No,
we're
sev-
now almost a year on treatment?
oh, that's long. That's long. But if he's tolerating it well?
He is. We had to decrease the dose slightly just to make everything happier, but he's tolerating, I mean, other than a shot a day for a 10-year-old is
Yeah.
miserable, but other than that, he's tolerating it very well. And we're seeing, on the scale, the pinch scale of the skin and things like that they do, every month when we go back to the hutch, we're noticing a very small, half a point difference, but that's still, we're going in the right direction.
And I think just because these things are so far out there in our knowledge or beyond, as long as it works and you see continuing improvement, it's worth trying.
Okay, thank you.
Yeah.
We have another question. Here and then here. I think those will be our last two.
I gotta let you say something.
Hi, I have graft-versus-host. I have the scarring and the thickening and shiny legs. Luckily, I don't have too many mobility issues. And I was put back on prednisone about 2 months ago, and am being actually tapered a little bit. But I have two questions. One is, will the dimpling ever go away, or is this pretty much long sleeves from now on? And the other question is, while I can live with that, I'm okay if I have to wear long sleeves the rest of my life, but as far as progression of that type of scarring, you had mentioned organs, and I assume that the lungs or kidneys or something like that would be involved. When do you know that that is starting to happen, or how should that be prevented?
Okay. So the first part of your question, some dimpling, it probably will not go away. You've been treated for quite some time now.
She can't hear.
No, I've only been treated for about 2 months.
2 months?
Yes.
Oh, then we'll see. So it might go away. As far as inner organs, so kidneys are normally not affected, but lungs can be affected. It's more rare. You'll notice you'll get short of breath or start coughing, and then we have to do a bunch of pulmonary function tests, and then we make the diagnosis. But it can happen as late as a couple of years afterwards. Still, I don't want anybody living under the fear, I'm going to get lung GVH, I'm going to get lung GVH. You all have learned to live under the sword in a way. So I'm the last one to give you coping advice, but it's most likely not going to happen.
Well, I pretty much consider this my new normal, so I'm going to be on prednisone at one level or another.
And we have one last question.
I just have a quick comment to add, though, in terms of the dimpling, and I agree with Dr. Mayer about physical therapy and keeping your muscle stretching and working the skin, moisturizing the skin. We have seen it get better, and as he said, you're only on treatment for a couple of months, so it could possibly get better with time.
Good morning. I have two questions. One is you talked about adjunct treatments, and I'm wondering what you think about lymphatic drainage massage, which I've been going for to a private massage therapist, and then I just went to one in a physical therapy center at a major medical center, and the woman there said it only helps for like 20 minutes. It doesn't have a long-lasting thing. So I wanted to know your thoughts on that. And the second is, you mentioned recurring skin cancers and something you give patients, which I didn't get. I've had all three of those. I did the trifecta. I had basal cell 10 years ago. And then the last 4 months, I've had a squamous cell and melanoma, both on the same arm. So those are my two questions.
Okay. You want to talk about lymph drainage? So lymph drainage massage, as most people probably know, is mostly used after breast cancer surgery when they take out the lymph nodes and the arm blows up. One of the effects, not that common, but still seen often enough, of skin GVH is swelling. And yes, lymphatic drainage helps, but it really is only a temporary measure, unless you want to keep your arm or the affected limb in a compression stocking all the time. 20 minutes, that's a pretty short-lived relief. If it's 20, I don't think it's really worthwhile. If you get a couple days, that's a different story. If it's not working for you, then it's not working. With regards to the skin cancers, so you need to see a dermatologist probably every couple months. Preferably the same person who knows your skin, and you will know your skin by now too. There are these retinoid drugs that one can take to decrease the rate of skin cancers. It doesn't always work, but I have one patient who had a new skin cancer every time I saw him. He was getting quite exasperated. And we started him on the retinoid drug, and it really has slowed the rate at which they pop up. Now, could it be coincidence? Yes, but there seems to be a role for these drugs. But the key is to have very close surveillance. And then, they will have to repeatedly go at it with the scalpel, but it won't progress.
And the drug is isoretinol?
It's called Accutane. Accutane. Yeah. Sure.
So I'd like to thank Dr. Mayer and Ms. McKinnon for not only presenting but answering your questions, and it's time to move on to the next session.
Thank you very much.